Yeah, thanks again for the invitation to this prestigious symposium. I start with my disclosures, also saying that I started as a surgeon before I went into internal medicine, just as a reference to an eminent speaker of today.
Cardiac surgeon, right?
Actually, cardiac surgeon, that's true. Okay, so I have 7 minutes, and I would like to answer the question of the presentation. Actually, I would favor it to answer it by a randomized trial, but actually we don't have the answer provided by randomized trials, so I think we only have indirect evidence, and I will give you some indirect evidence in the next couple of minutes. So number one, do we have evidence that transplant is the recommended treatment of choice for high-risk MDS patients compared to current standard of care, which is mainly azacitidine? I think yes, we have. There are 2 clinical trials, one US-based, one German trial just recently published showing that transplant is superior to current standard of care in high-risk MDS patients. I think the intention to lower the blast count prior to transplantation is to lower the disease burden, and by doing so to improve outcome after. So what about blast count in general? Do they matter or are they neglectable? According to the current prognostic models, you see blasts do matter, but if you weigh the blast count in the prognosis of a given patient, you see that genetics, in that case cytogenetics, are more important and add more importance also on the prognostic value in a given patient. This is especially true also with the, if you see with the IPSSR here, we have the very low, nobody would actually consider transplant, but and high and very high, I think those are the patients in general we would consider. Intermediate is a box where I think molecular abnormalities are needed to define the patient path. But if you look for instance, the very high IPSSR patient, a patient has a median survival of 0.8 years with supportive care only. So not doing something in the time between donor search and transplant may potentially put the patient at risk to basically die of its disease. And this is not only true for the IPSSR, but also for the IPSSM. With supportive care only, actually the prognosis remains bad. So if you consider not to treat a patient with high-risk MDS prior to transplant, you need to keep in mind also the natural course of the disease. What about blast count prior to transplantation? Is that of importance for the prognosis? Yes, it is, as you can see here from the Seattle study, which I think is still valid. But genetics, in that case cytogenetics, are more important and are the major driver of the biology of the disease. Of course, if we consider transplant in a given patient, we have several variables which being important for the outcome of the patients. Disease status at transplant, as you can see here, is important, but I think it's a large box of variables where age, comorbidities, and again, genetics are the most important to consider for outcome. So what kind of opportunities do we have to lower the disease burden prior to transplant? Disease-specific therapy is, of course, something we can consider. We can also intensify conditioning. We can also, of course, implement maintenance and MRD trigger treatment. So Ari already mentioned that it's always good to look at guidelines, and these are the ELN guidelines. And they say if you have more than 10% bone marrow blast, consider cytoreductive therapy and then proceed to transplant. Less than 10%, also a direct transplantation could be considered. In general, if we consider therapy in given patients, we have also to consider the therapy-associated mortalities, which comes with a given treatment, but also the likelihood that the patient responds, because the ideal situation is that the disease burden goes down, but many patients also progress while on treatment, so you may accelerate actually the disease biology. What we can do at this stage, given to the approval of HMA, is azacitidine or decitabine in the US with a CR/CRi rate of approximately 20 to 30%, and there is no biomarker actually to predict the response. Just taken from our German Vidaza-Allo trial, where we actually gave azacitidine 4 to 6 cycles in every high-risk MDS patient prior to transplantation, and you see that we lost roughly 1/3 of the patients on their path towards to transplant, and this was also because of not only adverse events but also patients actually progressed. And this is the case here that treatment, a given treatment, especially being not selective, may on the other way select also for clonal progression and may accelerate the disease biology. So there have been recent efforts to do an upfront allogeneic stem cell transplantation. These are retrospective data. No randomized prospective trial does exist. And what you can see here is that the patients receiving upfront transplant were younger and had a less advanced disease stage. And of course, such a strategy also requires that you get a donor on the ground pretty fast. What about ASA versus induction? Again, retrospective data from the French group suggest that there's no difference in outcome after transplantation. But I think the talk by Guillermo nicely showed that we are at a step potentially where we can add new agents to HMA-based therapy with a CR rate exceeding 40, maybe even 50%. Just a presentation at the ASH meeting showing a marrow CR with HI rate of 71% of high-risk MDS patients who basically underwent subsequent stem cell transplantation. So therefore, I would say yes, if we have such kind of opportunities, I think maybe not every, but a high amount of patients should potentially receive treatment to bridge donor search. But molecular aberrations are detrimental, not only to define the prognosis, but also maybe to define the response to a given treatment. So personalized therapy may be the future to select which patient for how long should a given treatment and which patient should not receive therapy prior to allogeneic stem cell transplantation. So within 6 minutes and 45 seconds, I try to convince you that still to bridge or not to bridge is the question. And I think it's not answered by randomized trials. We still have limited options outside clinical trials, but I think the future is bright, at least to my understanding, because there will be the availability of tailored therapies, which will also offer novel avenues for our patients. Therefore, my anticipation, if we repeat this symposium in 5 to 10 years, the question is not whether or if we treat a patient, but which patient and for how long prior to allogeneic stem cell transplantation. So for now, I would say fast-track transplant is advisable in vulnerable patients and those with high-risk features like, for instance, P53 mutations. However, clinical trials are needed. With that, I would like to thank you and happy to take questions afterwards.
Thank you, Uwe. And to argue no is Dr. Christopher Gibson.
Okay. Well, thank you all. My name is Chris Gibson. I'm in the bone marrow transplant group at Dana-Farber in Boston, and I am all that is standing between you and the bright Southern California sunlight, which is streaming in the windows outside. So I will also try to keep this very short and sweet. So just to break the fourth wall a little bit, we were assigned these topics, and I was assigned a position that does not conform exactly to my own clinical practice, and I could not bring myself to take the absolutist position that cytoreduction should never precede transplant for MDS. So I amended the title slightly. The cytoreduction should not uniformly precede transplant for MDS. I'm still going to quickly walk you through some reasons why we should think carefully about universally applying cytoreduction for all patients with MDS. But then I'm going to, at the end, tell you a little bit about what my own clinical practice is. I have no disclosures. I think we all know already what we mean when we're talking about cytoreduction. The only thing that I would say here is that sometimes when people talk about cytoreduction, there's a little bit of a valence that they're implying it's for patients who have high blast count. And for a little bit of a straw man argument, I'm going to extend that and say here, I'm really talking about cytoreduction agnostic to what patients' blast counts are entering and saying that it is not appropriate for some patients, especially those with lower blast counts. Okay, so the first broad point here is that there is no data that, broadly speaking, that cytoreduction prior to transplant improves outcomes for high-risk transplant patients. And as Dr. Platzbecker already told you, there are no prospective randomized studies addressing this question, so what we're left with are a variety of retrospective studies, but those have, in general, all shown equivalent survival for patients who received hypomethylating agents or intensive induction therapy prior to transplant compared to those who went straight to transplant. Now, obviously, there are significant caveats to this. The biggest is that these are retrospective studies, and as Dr. Platzbecker told you, there is good evidence that these are not necessarily equivalent groups, and that the patients who receive cytoreduction may often be higher risk up front, so this is not necessarily a fair comparison. Many of these studies also included secondary AML and MDS, and patients who achieve complete remission may actually have better outcomes, but this really applies in these studies mostly to AML because we don't often see what we would consider true complete remissions in MDS patients. But MDS is a heterogeneous disease, and it's largely lumped together in these studies. So then the next question is, what if we look specifically at those patients who have effective cytoreduction, who actually have a response to cytoreduction? Do those patients have better outcomes after transplant? So this is a molecular analysis of the CTN 1102 study that we recently published in JCO, and I selected here some analysis of patients with p53 mutant MDS. Now, this is a little bit of an unfair comparison because, as we know, p53 mutant MDS is very high risk, and also what we found here was that almost none of those patients in our study molecularly cleared their p53 mutations using sensitive detection. And this is in contrast to the ASH abstract that Dr. Garcia-Manero referenced in his talk, and so we have a little bit of a different finding here. But what we found is that when we instead binned patients who had high allele fraction p53 mutations going into transplant, and those who had low allele fraction in p53 mutations going into transplant, there was no difference in survival after transplant. And that is a proxy to some extent for a response to therapy, because most of those patients had received therapy prior to transplant. And so if we look at whether or not there was any difference in the p53 allele frequency entering transplant, we really didn't see that even that predicted outcomes. However, if we just said that, if we were to just say that cytoreduction is not effective, that wouldn't be an entirely compelling argument for why patients shouldn't universally receive it. So the other question is, are there any harms to delaying transplant? And actually there are, and the harm is that the risk is that patients become ineligible for transplant during the time that we're giving them cytoreductive therapy. This is from the other major no-donor study that was published, and this is actually from Dr. Platzbecker and his colleagues. This also showed that patients with high-risk MDS had a benefit from transplant, but what it also crucially showed was due to an interesting part of this study, which was that all patients received 4 to 6 cycles of hypomethylating agent prior to assignment to the transplant, no transplant group. And during that time, there was a high rate of dropout, even before patients could make it to allocation to the study arm. I actually looked back at the paper during the talks earlier, and I think my numbers here actually even underestimate the degree of dropout. I think only 67% of the patients who were originally enrolled in the study actually made it to the transplant allocation. And a lot of that was because of progression to AML during the time that they were receiving cytoreduction therapy. Also, some of the patients died of infections or had other reasons that they were unable to proceed to transplant. So there is a cost to delaying transplant for many patients. So it does not appear to be globally effective. There's a cost to it, and yet in my own practice, I still do it sometimes. And so I'll just sort of close by telling you what my own practice is. And I think what I try to capture here is that I think the trajectory of disease really makes a difference as to whether or not I personally think the patient should be cytoreduced before transplant. So I do not cytoreduce, obviously, patients who have MDS with less than 5% blasts, so patients who are high risk for other reasons, going to transplant for other reasons, don't cytoreduce those. I also don't cytoreduce patients who are borderline transplant candidates, where I think that those patients are reasonable transplant candidates, but they really may only have one shot at curative therapy, and I don't want to blow it. I try to take those patients as quickly as I can, and I'm skeptical of giving them too much cytoreductive therapy. On the other hand, I nearly always cytoreduce patients whose MDS shows rapidly increasing blasts, where I think that there's a clear trajectory towards leukemic transformation, and certainly also patients who have 10 to 20% blasts, even as a snapshot in time, because I think that those patients also sort of represent a group that's likely in transition to leukemia. And then finally, I sometimes cytoreduce patients who are in that intermediate zone of 5 to 10% blasts, but it really depends on the trajectory and the scenario. So someone who's been observed for some period of time and is now just kind of nudged over the threshold into 6% blast or something like that, I don't necessarily think of those patients as being someone who really necessarily needs cytoreduction. And as Dr. Platzbecker alluded to, when I do cytoreduce, I try to keep it brief to not lose that opportunity to get them to transplant that might come with a delay. So that is in sort of that concludes my talk. So my summary here: there's not a benefit. There's no evidence for a broad benefit. Some patients it's possible that some patients who have a response to cytoreduction may benefit from transplant, but we don't know who those patients are. And there definitely can be a cost to delaying transplant while we cytoreduce. So I think the closing message from me is that I pick my patients carefully who I try to cytoreduce and try to get them to transplant as quickly as possible. And with that, I'll conclude. Thank you very much.